Hey guys, so today we are gonna go over diabetes. Um, we're gonna touch up on a little bit about what diabetes is and basically the management of care for your patient. So, if you guys know me, I like to go over the pathophysiology a little bit or kind of like explain to you guys what these certain diseases and processes are so you better understand what is happening in the body and why we are seeing the signs and symptoms that we are seeing in the patients. So, diabetes has to do either with the function of the pancreas, the role of the insulin in the body, that the patient is not either making enough insulin or it's just not being recognized in the body. So, either they have less insulin or impaired use of insulin. So we have we have two types we have two types of diabetes. We have type 1 and type 2. Usually type 1 is genetic, seen mostly in African Americans and Hispanics. And when we're dealing with type 1 diabetes, we're talking about the pancreas not making any insulin, meaning that these patients are born and their pancreas is basically not making insulin. Okay? So, with these patients, it is required that they are going to be injecting insulin for their whole entire life. Now, we have type 2 diabetes, which this one is the one that could be acquired. There could be cases that the child is born with it, but usually it is acquired during lifetime, and usually it's because of unhealthy eating, obesity, lack of taking care of yourself, um, there could be like a lot of issues and risk factors, and usually this is not because the pancreas is not working. There are patients with type 2 diabetes that their pancreas is working fine, but maybe they're not um, producing as much insulin as it's supposed to, or the body is being basically the body is like kind of like refusing to recognize the insulin. Okay, so those insulin receptors are not working, meaning that even if they do have insulin in their body, it's not working properly. Okay, and basically both of these diabetes have the same thing. It doesn't matter if they have type 1 or 2, they are going to have the same clinical manifestations. And this is something very important for you guys to know for your exams and for the future. So, usually, you are going to find out that the patient has diabetes if they don't know, because they're going to have the 3 P's. The 3 P's is polydipsia, polyuria, and polyphagia, meaning that the patient is going to be peeing a lot, they're going to be hungry and thirsty. Okay, these are like mostly like the common manifestations that you're going to see a patient coming into the hospital not knowing that they have a diabetes, unfortunately, and then they're kind of like a trigger, like, okay, we have to check for diabetes because this could be a case. Now, that is your clinical manifestations when a patient has diabetes. These are like the signs and symptoms. Now, you also need to know signs and symptoms that a patient will have when their glucose is high or low. Very, very important for your exams and also for your daily life as a nurse, because when you have a diabetic patient in the hospital, you need to know, if they're coming up with clinical manifestations. Just looking at them, you will notice if the patient has high or low glucose without doing a glucose check. And it is very important that you stabilize these patients because they could end up in a coma. Okay, so for hyperglycemia, this is when the glucose is increased. So think about the patient or the saying hot and dry, blood sugar high. So it means that the patient's skin is it tends to be dry. They're going to feel like very warm to touch. They're gonna have itchy skin because of dryness, fatigue, blurred vision, and also slow wound healing. The way that I remember is that bacteria loves sugar. So if the patient has high sugar, the bacteria is going to keep on feeding on that glucose, and the wounds is never going to heal because it's just feeding off from that high glucose. Okay, so we'll get into that a little bit more into depth in regards to wounds and foot care. But just keep that in mind that bacteria loves glucose, and when the patient has high glucose, it causes slow wound healing. Now, for hypoglycemia, this one is more, I wouldn't say that it's more important because both of them are very important to treat, but I personally rather have a patient in hyperglycemia than in hypo because the treatment is easier when it comes to lowering glucose and having to higher it. Having to higher glucose is very, very hard. It takes a while, and these patients are really, really close to being comatose if their sugar is below 30. Okay, so for hypoglycemia, think about cool and clammy, need some candy. So you need to give them sugar, and they are actually going to be the opposite. They're going to be cold to touch and very, very clammy. Okay, um, so they're going to be sweating, have hunger because the body is like, hello, I need some sugar. They're going to be trembling because remember that glucose is energy. So the body is basically like, where's my energy? Where is everything? You know, where is all of my energy that I need to keep on going? So we'll start going into like a trembling, anxiety, and confusion state. And also they're going to have blurred vision. Usually for your exams, they don't pinpoint something that is similar with them. So for example, blurred vision is probably not going to come up on your exam. It's going to be focusing on like the sweating, which is the one that I normally see, the trembling, anxiety, and confusion. Okay. And of course, for all patients, usually they start decreasing in weight, even though you see a lot of type 2 diabetic patients, like obese and stuff, they do tend to be losing weight during the diabetes state. So the way that we diagnose diabetes, the one that is very, very important is your HbA1c. This is an exam that is going to tell you if a patient is actually diabetic or not. The reason that the fasting blood glucose and the urine ketones are not going to help you diagnose a patient if they're diabetic is because it's a generalized thing that is testing you at the moment. With the HbA1c, this exam is actually testing your blood glucose percentage for 3 months, okay, from the past 3 months. So if I do an HbA1c today, this is going to get the percentage of how high my glucose was 3 months ago from today, okay? Fasting blood glucose is just going to take your glucose right now. So let's say that I take my blood glucose now and my glucose is good. That doesn't mean that I don't have diabetes. It means that it's controlled at the moment, but it doesn't mean that I'm not diabetic, right? So the fasting blood glucose is not something that you use to actually diagnose a patient with diabetes. It's just used to manage it, okay? So for your exams, make sure that you guys know the difference. One is to manage your blood glucose and another one is to actually diagnose you diabetic or not. The urine ketones, we'll talk about it when we go over DKA. This is basically a urine exam that will test ketones to see if the patient is having diabetes ketoacidosis. So for the HbA1c, I want to touch back up on that this is the exam that is going to be basically telling the doctor like, hey, this patient is diabetic or this patient isn't diabetic. So the normal HbA1c should be between 4 to 6, meaning if you do an HbA1c and you score in that percentage, you're not diabetic, you're good. Okay, that's regular percentages of glucose. Now, for a diabetic, it's going to be above 6.5 or 6 to 8%. When a patient has this type of percentage, this is basically telling you like, okay, this patient is diabetic. Once the patient is diabetic, like once they're diagnosed as a diabetic patient, type 1 or type 2, whatever the case is, HbA1cs are going to be done quarterly or every, like at least either, I think it's 4 times a year or 2 times a year. It all depends. I'm pretty sure that it will be more frequent at the beginning when they get diagnosed, versus when they've been for years with diabetes, and it's going to be twice a year. But anyways, the target goal for a patient that is diabetic is less than 7%. Of course, their percentage is going to be greater than between 4 to 6, because they're already diabetic. So, even if they control their glucose, there is a possibility that they won't be in the normal range because they're already a diabetic person. But when they are diabetics, we're trying to keep that percentage at a 7 or below, okay? And like I said, this is going to be a test that is going to average out and give you a percentage of the glucose that you have had for the past 3 months from the day that you do it. Okay, so very important to keep that in mind, because there is a high possibility that that could be asked. Now, for your fasting glucose, if you guys ever been to clinicals, or if you guys have a family member that is diabetic, this is what they use at home and in the hospital to check glucose. It's just like the AccuCheck. Usually, the fasting glucose is done, NPO, like in the morning. The blood glucose exam, which is the same thing, it could be done through the machine as well. And it's done 3 times a day. So in the morning, before lunch, and then before dinner. Okay, so the fasting glucose could be done through, blood drawn, but we could also get it with the AccuCheck. Okay, the fasting glucose is just gonna basically tell you how your glucose is doing when you're NPO, to see if the body is working properly that specific day. So like I said, the HbA1c is the one that's like the average. The fasting blood glucose is just gonna tell you like how the body's working like without food. And it could average out, like it's gonna be different every single day, so it's not something accurate. Okay, and then we'll talk about the urine ketones later on. And then to collect specimens for the ketones, so the urine culture, just make sure that you guys know the clean catch for that specific test. Now, for the glucose, you want to make sure that you know how to do the AccuChecks. Okay, so make sure that you guys take notes on this, because they might either do like a slide. I don't know if you guys ever seen like those questions that are like put them in order, or select all apply, whatever the case is. And you are going to have to teach the patient either way when you're in the hospital how to use an AccuCheck if they never have used it and they just got diagnosed with diabetes. So when you do the AccuCheck, you're first going to gather all your materials. So what you're going to need is the monitor and the strips that are compatible with the monitor. Make sure that you know that those strips have to be compatible with the monitor, or it will not work. Okay, so just think about brands. If the machine is one type of brand, it's going to be compatible to certain amount of strips. Not every single monitor is going to be able to hold every single strip. You do have to let that patient know, because they have to obviously continue on buying strips for their monitor. You're going to grab alcohol wipes and cotton swab, like not the like cotton balls. And then I always like to have like tape as well, just in case like the patient is like a little bleeder or something. I can make like a little bandage, or you could just get a little bandage. But the most important thing is the monitor and your strips, your alcohol wipe, and then also your little needles. Okay. Just look up on Google like how they look. They have like a little safety lock, and then it's like a specific little needle that pinches and punctures your skin, so the blood can come out. Now, when you have all your materials and you explain to your patient like what you're gonna do, you're going to ask your patient like, hey, like which finger do you prefer? Usually, if they have been diabetics for a long time, they really don't care. You're going to notice that their fingers are going to be a little bit hard. So you're going to try to find the best place. But I always like to ask my patient just because they have like a preference. Now, when you're going to pinch or you're going to pick your site, look at your finger right now. Like, look at your hands and put them, like, look at the side of your fingers. You see where your nail bed is, like on the side, not on the bottom, like where your fingerprint is, but a little bit towards the middle of your fingerprint and where your nails are, like the side of your finger basically. You're gonna see that it's like very spongy and easy. Okay, that's where you're gonna do it. You don't want to do it where the fingerprint is because it's gonna hurt more. You always want to do it on the side because it's less painful and you're still gonna get blood flow. Okay, so on the sides of the fingers are always the the specific parts that we like to do it. And then I always like to have the patient put their hands like going down because you want the blood flow to go straight down to your fingers so you could get a good amount of blood, because if not, then it's gonna come out bad. Like the monitor is gonna tell you that you don't have sufficient blood, and then it's gonna be like you're gonna have to pinch the patient again in another area. So you want to make sure that you massage the finger first. You well, whichever the one that the patient tells you to, you massage it, and then you have them place it like the hands going down. I wish I had like a video to show you guys, but kind of like put your hand like going down, like if you're gonna put it down to the floor, and you feel like the rush of like the blood going down to your fingers. And then remember, you're going to pinch on the side. So before you pinch, you're going to clean with alcohol, of course, and you're going to see that there's going to be blood. The first blood that you see, you are not going to use because you just wiped the finger with alcohol. So if you pick that up in the monitor, it's going to give you a wrong number because it's going to be a mix of blood and alcohol. So the first drop, you're going to wipe it off with the cotton ball, and then you're going to get the following blood, okay? And you're just going to put it on like on the little stick, and then you're going to have it like, it's going to read it, and then that's going to be your glucose. Make sure that if you are dealing with patients on anticoagulants and things like that, little sticks like that will bleed for a very long time. So have the patient hold a cotton ball for at least a minute or two to make sure that it clots, or you stay there with the patient, so for sure that they're not bleeding from the site. Okay, so make sure that you guys know that. Watch videos. I believe there's like an ATI video in the ATI. I think it's in the skills modules. Watch it so you guys could have like a visual of what I'm talking about. So when you guys are taking the exam, you have my voice in your head, but also, a visual video of it. Okay. So basically your education is educating the patient on how to use the monitor. Obviously, hand hygiene before everything, and you're going to explain every single step that I just told you to your patient. I usually like to tell the patients to buy like a little book to document. There's a specific book for blood glucose checks, and it's going to have like the time, it has like times and stuff, and then like little boxes for them. But it all depends, like whatever the patient wants. Just educate the patient that they do have to take their glucose before breakfast. Like they have to take a fasting glucose check at least once a day. So basically before their breakfast, have them check their glucose, and then before lunch, and then before dinner. Okay, so for the exam, you guys do need to memorize this chart. You guys are going to need to know the onset and at least the peak of every single incident. So your rapid acting, your short acting, your NPH, all of that, you guys do need to memorize. This is just a memorization type of thing. I can't really, educate you guys on how to memorize. You just have to memorize it. The only thing that I want to touch up on is when you're giving insulin, you do have to make sure that you keep in mind that insulin lowers glucose. So you have to make sure that the patient eats after you give them the insulin, and they have to have food in their in the hospital room, because remember that when a patient is in the hospital, anything could happen. And yes, the kitchen is supposed to bring up the food at 9 a.m., but what about if something happens in the kitchen and they don't bring it up at 9 a.m. and you gave them the insulin and the food hasn't arrived and they're already at their peak level or their onset level? Their glucose is going to drop. You put the patient in hypoglycemia, and now you have to treat it, and then it's going to be on you. So every time that you give insulin at the hospital, you do have to make sure that they have their food there. And you have to educate your patient. Hey, I'm giving you your insulin. You have to make sure that you eat right after I give it to you, or at least within 10 to 30 minutes or whatever. Usually tell them 10 to 30 minutes no matter what insulin it is, but different incidents have different onsets, okay? Apart from that, you do have to educate the patient, like when they go home with insulin, of course, that they have to monitor their glucose, and then they eat. They give themselves the insulin, and then they have to eat, of course. So you educate your patient on like whatever insulin they're gonna go home with, or whatever medication that they're gonna go home with. But at least for the hospital, make sure that you have the food in the room before you administer. So that means before you administer the AM one, there has to be breakfast in the room. Before you administer the lunchtime one, there has to be lunch in the room. And before you administer the one for bedtime, there better be some dinner there before you give it to them, okay? Because especially at night, you're going to think that the patient is sleeping, and what they are they're in comatose because they didn't eat. Now, there are going to be patients that obviously don't want to eat, that they're refusing foods. If that's the case, always have like orange juice with a lot of sugar. You have to have them eat something, okay? So you do have to educate the patient, and let them know, like, look, I have to give you the insulin, you have to eat something. So if it's not food, it has to be liquids, orange juice with a lot of sugar, something that will maintain their blood glucose stabilized, due to you giving them the insulin. Okay, so like I said, make sure that you memorize the onset and the peak. Okay, the questions could be as simple as what is the onset of NPH, what is the peak of NPH. Okay, the questions could be that simple. Okay, so as long as you memorize it, you should be good to go. So your actions as a nurse to provide insulin. You do have to educate your patient, of course, if they're going to go home with insulin, because these patients don't know how to inject themselves. But the way that you're going to do it is that you're first going to teach them. So the first few times, maybe have them watch you. And then you always have to do it at a 45-degree angle. Unless the patient is like really skinny, then you're going to do a 90. But for testing purposes, you're always going to tell the patient that it's at a 45-degree angle, because we want to get it into the subcutaneous. We don't want to get it into the muscle. Okay. So, sorry, I lost my train of thought. Okay, so before the patient gets discharged, you cannot discharge the patient and ask them like, hey, okay, so you know that you have to check your glucose, and you have to give yourself insulin. Do you know how to do it? And the patient's like, yeah, sure. No. You are going to make sure that you know that your patient is going to go home and they're going to be able to do this. Meaning, you have to visually see the patient. So this goes in regards to insulin insertion and also for the AccuCheck. If you guys get a question on your exam that it tells you, how do you know that the patient is basically let me see, how can I say it? How do you know that the patient is ready to go home, or that they're ready to do their own AccuCheck, or that you know that they're ready to do their own insulin. The answer choice is always going to be that you observed the patient doing it. You didn't do it for the patient, you had them do it on themselves. Because you have to visually see the patient and say, okay, the patient does know how to use it, or do it. Because the patient could tell you, yeah, I know, and then by the time that they go home, they look at the stuff and then they're like, oh crap, like I forgot how to do it. Usually, think about it, you don't really learn something, or you don't really learn a skill until you actually do it on your own, right? And sometimes you have to do it multiple times to actually get it right. So you want to have your patient do these things here and there in front of you instead of you doing it on them, so you visually can confirm that they're going to go home, and you know that at home they're going to be able to do it. Okay. Now, another thing, when you give insulin, you do have to keep on monitoring your patient, and also let your patient know what signs and symptoms to call you about. If you give them insulin, let them know, hey, if you feel dizzy, if you feel down, if you feel like really sleepy, if you feel like confused, if you have a bad headache, like let me know, because you have to monitor them for hypoglycemia. Even if they eat, there could be a possibility that they could go into hypoglycemic reactions. So the more you educate your patients always about what they have and what's going on, the better you're going to prevent situations from happening, okay? Because the last thing that you want to do is have the patient go into like a coma or something because of you, okay? Now, if by any chance you get a doctor's order that they are prescribing 2 insulins, and they're prescribing the regular and the NPH, which is something it's usually done in the hospital for maintenance, but you need to know how to draw up the insulin, because it's going to be in one syringe, okay? These are the only ones that I believe regular insulin and NPH are the only ones that could be mixed. The other ones have to be in a separate needle. So just in case you guys get a question on this, I know that there was supposed to be a validation. I'm not sure if you guys get validated on this, but they do validate to see if you know how to draw up these insulins. So you're going to get all you're going to get both of your insulins. You're going to get your regular and your neutral, which is your NPH. And usually your NPH is going to look like a little bit cloudy and have like little particles inside. That's normal. That's the only insulin that should be looking like that. Every other insulin should be very clear, and there shouldn't be anything inside. You're going to puncture inside both vials the air that you need, and then you're going to go in and withdraw the regular insulin. You're gonna have the second nurse witness, and you're gonna show them like, okay, look, this is the amount of regular insulin, and then you're gonna go ahead and withdraw the NPH, and then you're gonna have the nurse check again. Okay, remember that every time that you give insulin or you prepare the insulin in a syringe, there has to be a secondary nurse to confirm. In this case, the secondary nurse has to confirm twice, because you're withdrawing 2 types of insulins, okay? So I always remember RN. So R comes before N. So you withdraw the regular before the neutral, okay? And then that's how you give the patient a mixed insulin. All right. So complications of diabetes is very important to know, because they might ask you in regards to this, and it's something that you have to monitor the patient and educate the patient, because within their lifetime these things could happen, and they could occur, or they could worsen, okay? So the patient could be at risk for neuropathy, nephropathy, retinopathy, circulatory complications, delayed wound healings, and risk for infection. Remember, risk of infection because of high glucose. Bacteria loves glucose. Delayed wound healing because bacteria loves glucose. Okay, circulatory complications, you're going to see that these patients are going to have like varicose veins. They're going to have swellings and edema in their legs, in their feet. So it's very, very common for them to have circulatory complications. Neuropathy is that they are going to have issues with their nerves. So this is why I'm gonna go over foot care, because their nerves are gonna stop they're not gonna stop working, but it's gonna eventually they stop like working as they should. So in some areas they might not feel something that they're supposed to feel. Like for example, if they have a wound, they might not feel the pain or anything because their nerves are not working properly in that area. Nephropathy has to do with the kidneys. So these patients do have to monitor their kidneys, especially if they're like on medications and things like that. And then retinopathy has to do with vision. So usually these patients have to go to the eye doctor every like twice a year, around there. Okay. So for circulatory complications, like I said, they could have edema, they could have varicose veins. They are prone to having atherosclerosis, especially if they're type 2 diabetics, because they might have gotten this because of obesity and things like that. So these patients are prone to getting CAD, heart attacks, and strokes. Okay. So circulatory problems are very, very common. So the neuropathy, like I said, they're going to have like desensitization of different parts. Usually it happens in the lower extremities, which is why foot care is very, very important. And I'll discuss it later on, like I said. And then diabetic retinopathy, basically this is going to damage their vision. So this is why they have to see their vision, like they check their vision like at least twice a year, okay, once they are confirmed that they are diabetics. Diabetic ketoacidosis is when the patient has a blood glucose of over 300. So this is the one that we were talking about, that they have to do a urine test to check for ketones. There is two types of high-threatening conditions, which is DKA and then HHS. Okay, for DKA, their blood glucose is going to be above 300. Usually it's because they are not controlling their glucose, or maybe they don't even know that they're diabetic, and this is usually how they find out that they're diabetic. Okay, so HHS is another life-threatening condition, like I said, but this one is when the glucose is above 600. So what I want you guys to know is this, which is the expected findings and the difference between DKA and HHS. The way that I learned it is learning what one has and the other one doesn't have. For example, DKA has a fruity odor breath, Kussmaul respirations, and metabolic acidosis and ketones in the urine, which HHS does not have. Always think about K for ketones. DK has it's diabetes ketoacidosis, so it's because of the ketones. So because the patient has ketones, and I'm going to explain to you what ketones are. Ketones are basically like, I guess if you want to think about it like an acid, it's like bodies of acid that builds up in the body because the body is trying to how can I explain it to you? It basically breaks down. So there's fat metabolism occurring in the body, and then that metabolism causes ketones, which is acid particles. Okay, so it's fat acids that are broken down in the body because of, and then that increases the ketones, and then since the ketones are acidic, that's why we're gonna see metabolic acidosis because of the acid. We're going to have a fruity breath odor, which it doesn't actually smell like fruit. It smells disgusting. And then small respirations because of the acid. You're trying to excrete that carbon dioxide and that acid from the body. Okay, so those are the things that you need to make sure that you know for DKA. The fruity breath odor, small respirations, metabolic acidosis, and ketones in the body. If you guys have a selector that apply, that's what you guys are going to be asked for. Okay, for HHS does not have metabolic acidosis, does not have small respirations, does not have fruity odor of breath. Why? Because they do not have ketones. Okay, HHS does not have ketones in the urine. So that's how we know that the patient has HHS, because there's no ketones in the body, the blood glucose is high rocket, and basically HHS could lead into seizures and reversible paralysis because of how high the glucose goes. Okay, so please make sure that you guys know that, because for sure that's going to come up eventually for you guys. And then the way that we treat DK and HHS is very important. You might get a question in regards to this. So remember that for these patients, their glucose is very high, right? So the way that it's treated is that we're going to put them on insulin. We're going to give them a bolus of insulin through their IV. This is a large amount of insulin, rapid. So we have to monitor the patient, because yes, the patient has maybe 600, 700, whatever the number is, and we do have to decrease it, but we don't want it to decrease so fast. So once the patient reaches a glucose of 250, we have to put them on dextrose. Okay, I think it's D5W, the one that they use in the hospital. But dextrose, what it is a fluid that has glucose in it. So yes, you're gonna ask me like, okay, Gabby, but why are we gonna give them glucose if 250 is still high? Like I said, we don't want to shock the body and just drop the insulin, the glucose from 600 to 100. Okay, you have to let the body like kind of like, you know, go from one state to another, but not fast. So once the patient goes into 250, you're gonna keep the patient on regular insulin, because you're gonna put them on a drip, but you're gonna put them on D5W. Okay, so this is like a balance out. Like you're giving glucose, but you're also giving insulin, so the body could come back to its normal state. Okay. And then you also want to make sure that you monitor your potassium. The reason why I say this is because potassium is taken into the cell. If you want to think about it in like a pathophysiology state, your potassium is usually outside of your cell. Okay, and insulin, what happens is that it basically pushes the potassium into the cells. So when you are giving large amounts of insulin, it could alter the potassium and decrease the potassium. So you want to make sure that you monitor it, because you might have to put the patient on potassium protocol. Okay, usually when a patient has high potassium, a way for us to decrease potassium is to give them insulin. Okay, you want to check their cardiac rhythm as well because of the potassium. And then you also want to give them sodium bicarb if they have DKA, because of the metabolic acidosis. All right, so foot care. This is going to go hand in hand with your neuropathy. These patients have to check their feet every single day. So for them not to forget, have the patient take a shower, and every time after the shower, they have to do foot care. They have to look at their feet every single day after they shower. So you want to tell them, to shower, clean their feet good, and make sure that they pat it and dry it very well. You don't want to leave it moist, because if it's wet or moist, it could cause skin breakdown, and you do not want to do that. And this is another reason why you have to educate them that they cannot put lotions between their toes, because it could cause skin breakdown. If the patient is prone to sweaty feet, especially in closed-toed shoes, you want to tell them to put a little bit of powder in their shoes, because you want to prevent, again, from the feet being wet. Okay, because wet feet causes skin breakdown, and if they have neuropathy, they're not going to feel none of that, because they don't have their nerve endings are not working properly. Okay, for their nail care, I want you guys to refer back to your ATI, your newest ATI, because it changes all the time. But I know for a fact that for nail care, they cannot cut their nails like in a circle. They have to cut it straight across and then file the sides. Okay, because you don't want them hurting themselves or cutting themselves, because when a patient is diabetic and they cut themselves, it's first they have circulatory problems and then they're prone to infection, so you don't want that. You want to let them know that the shoes that they have to wear should be closed-toed shoes, and they shouldn't use any shoes that could hurt them, like plastic or hard shoes. Okay, or open-heeled shoes, because they could get hurt in the heels as well. So everything is always like, I guess, having the patient protect their skin, especially their feet and everywhere, because of the neuropathy. Okay, I don't remember what movie it was, but it was, or like a video that I saw, that it was a patient that was diabetic, and he went on the whole entire day walking to the mall, to stores or whatever, and when he got home, he was bleeding like hell, like a lot. Like he had ulcers and skin breakdown, like breakages all over his legs. Obviously, it happened that day, and he didn't feel anything, because that's how that's how bad the nerves get, that you don't feel any pain. So now he has all those breakages in his feet, and now it's prone to infection, and it's gonna have slow wound healing, because it's very hard for them to heal. Okay, so that's why it's very important to educate your patient on that, because you don't want any skin breakages. You don't want them to get hurt. They should always wear cotton socks, and every time that they use pads, if indicated, they have to monitor themselves. They shouldn't be using any heating pads. They shouldn't be using anything, because just like I mentioned that they're not going to feel pain, they could literally burn off their skin, because they're not going to feel the heating pad. Okay. Now, another important thing is educating your patient on illness days. Obviously, we're all going to get sick. We do get sick. So when a patient is diabetic, they do have to monitor their glucose every 3 to 4 hours instead of 3 times a day, because the problem is that, remember, like I said, bacteria, and when you're sick, it loves glucose. So you do have to monitor your glucose more than before, and you have to educate your patient that the reason why is because when they're sick, their glucose is a little bit more unbalanced in their medications, and insulin is not going to work properly. Sometimes they're even going to need a larger dose, but that all depends on the doctor. So they have to continue taking insulin. So you guys might get a question in regards to this, and it will tell you which statement indicates that the patient needs further teaching. So if the patient tells you, oh, I'm going to cut down on my insulin since I'm sick, that one should be your choice, because that's wrong. They're supposed to continue their treatment, the same dosage, the same time. Everything has to be the same. Okay? They also have to take a 4 ounce of sugar-free beverages every 30 minutes to maintain their glucose. Okay? Now, you do have to educate your patient when to call the doctor. So if they continue on being sick for a long period of time, if they start becoming disoriented or confused, any signs and symptoms of hypoglycemia has to be called. Fever that's above 101.5. They do have to monitor their ketones at home. So there are ketone kits that patients could buy, and they should have it at home just in case they have like a sick day. They monitor their ketones because either their blood glucose could go down, but then it could also increase. Okay. All right. So we already talked about that. All right, and then we already talked about how to treat hypoglycemia. Oh no, we didn't. So for hypoglycemia, the way that we treat it is giving them 50% dextrose on IV and continuously monitoring this patient. If they're unconscious, you give them glucagon IM or subcutaneous, okay? Because they can't drink anything or eat anything.